Hi, everyone, and welcome to today's webinar, which will feature an expert panel and their approach to wound therapy for cost savings and better patient experience. This session is sponsored by Smith & Nephew. I'm Erica Spicer Mason with Becker's Healthcare. Before we get started today, I'm going to walk through a few quick questions and housekeeping instructions for our attendees. We'll start today's webinar with a presentation, and we'll also have time at the end of the hour for a question and answer session. You can submit any questions that you have throughout the webinar by typing them into the Q&A box that you see on your screen. We really look forward to seeing those questions come through. Today's session is being recorded and will be available after the event as well. You can use the same link that you used to log into today's webinar to access the recording. And finally, if at any time you don't see your slides moving, or if you have trouble with the audio, just try refreshing your browser. You can also submit any technical questions into the Q&A chat box as well. We're here to help. So with that, we look forward to hearing from our esteemed panel today. I'm going to go ahead and turn it over to our moderator for the day, Allison Seiler, the Medical Education Manager at Smith & Nephew. Allison, thank you so much for being here.
Awesome. Thank you, Erica, and welcome. Thank you all for having us. I'm really excited to offer this education and information to you all today. Please note that the presentation is provided for informational and educational purposes only, and our panel of speakers are paid consultants of Smith & Nephew. I am going to open it up or turn it over to our esteemed panel of experts to give a little bit of information about themselves and their role at the facilities that they work at. So I'm going to start with Miss Tammy. Tammy, if you want to give information about yourself and the facility that you work at.
Hi, thanks, Allison. My name is Tammy Dorsey. I am the Division Implementation Director for CommonSpirit. I am part of the Southeast over the Tennessee, Arkansas, Georgia, Kentucky, and Ohio area. Thanks.
Thank you. And Dr. James?
Hi, my name is Kelly James. I am an acute care and emergency general surgeon and trauma surgeon and wound care medical director out here in Kansas City. I've been practicing medicine and surgery now close to 30 years and wound care for approximately 15 years.
Thank you. And Dr. Littlejohn.
Hello, I'm Monty Littlejohn. I'm a trauma and acute care surgeon along with burns at Geisinger in Scranton, Pennsylvania. And I also deal with a lot of our wound care in our facility.
Perfect. Thank you all. I look forward to hearing from you, and thank you all for being here this afternoon. Tammy, we are going to start by hearing from you, and I want to hear a little bit about, as implementation director, what is important to you when you're driving implementation at your facility for new product or new vendors?
Well, we look at, we do a standardization across our entire organization. We look at our products and what is our cost-effective solutions, as you have up on the screen. What rolls out across to make a better effective, looking at our SKU reductions and what is cost effective that works across all 140 facilities to strive, well, as I said, I'm repeating myself, sorry, for cost reduction and SKU reduction, and works for cost effectiveness and still with good patient outcomes across all of our facilities.
Right. Thank you. 140 facilities. Wow. That's quite the undertaking, and I know you have a big chunk of that.
Yes, just 5 states, not all
5 states. Perfect. I want to hear a little bit from Dr. Littlejohn. And Dr. Littlejohn, what were some specific situations or maybe concerns with your past provider that led you all to look at a new option for negative pressure?
Yeah, thanks, Allison. That's a good question. In our facility, we utilize negative pressure wound therapy quite a bit, both on the inpatient and outpatient side. So we had problems in the past obtaining outpatient wound vacs, and that led to increased length of stay. And then really there was a ease of use of the VAC as well. So we'd had multiple issues in the past, which are actually now much improved.
Okay, perfect. And I know we'll hear a little bit more about that as we kind of move through the presentation. So we're going to move to Dr. James. And Dr. James, I know that you implemented the use of single-use negative pressure wound therapy several years ago in your practice. So I'd like to know a little bit more about why you choose to use this specific product when there are now so many single-use products that you could choose from.
Well, based on the technology of how the bandage works, and the ease of use it is for interchangeably shifting and making bandages fit your patient's needs on the wound, whether it was an open wound or a closed incision, I preferred this particular system because it came in so many variety of sizes and shapes. And when you applied the bandage, it was very effective in achieving the goals of lowering SSIs, wound adherence, and it was very simple for the nursing staff to keep monitoring. And plus, from an operative standpoint, as a surgeon, we liked the concept of putting a bandage on that was going to stay in place and not require a lot of maintenance, whether they stayed in the hospital or went to outpatient. So that technology is quite unique to this particular bandage. It doesn't require a lot of extraneous social services to obtain once the bandage is on. So if the patient left the hospital 2 or 3 days after surgery, the bandage was already on. You didn't have to go through a process of getting another bandage or setting up outpatient home health that would deal with that. The bandage just stayed on until the patient was seen as an outpatient.
Okay. All right. Dr. Littlejohn, I know we touched on this a little bit earlier, and I'm curious to know about some of the outcomes that you saw when you started to implement the new negative pressure. Were they comparable to what you previously used? And I'm curious to hear about some of the features and benefits of Smith & Nephew's negative pressure portfolio.
Sure. Yeah. So I think our outcomes were comparable both before and after the switch. Overall, that was the case. I think, like I mentioned earlier, there were better or improved times to discharge, with the addition of this technical support and hotline. But I think there are a lot of aspects of Smith & Nephew's portfolio that really helped us get better at wound care delivery, again, both on the inpatient and outpatient side.
Okay, awesome. And when you were looking at the products available to you, so you saw comparable clinical outcomes, and you said quicker discharge, able to get those patients' length of stay down. Were there anything specific about the portfolio that were easier to use or helped you achieve those outcomes?
Yeah, I think the addition of the soft port really helped with wrapping limbs. As you can see in this picture here, this is an extremity wound, and keeping those on, I think, was problematic in the past. So it's more comfortable to patients, can decrease pressure sores, but really, even the ease of use, we could put on an inpatient vac and then switch it over to the outpatient vac quite easily. And I think that process really has improved our throughput and patient care overall.
Perfect. All right, we are coming back around to Tammy, and I know that implementations are hard. They're a big undertaking, and especially with so many facilities involved. So if you could tell us a little bit about some unforeseen challenges that a facility might face when you're looking at changing supply vendors.
Well, when we change is hard. Nobody wants to change. Medicine's always evolving, so we always do have to change. We always have those So you've got that existing practice as you've got right here. The nice thing with the Smith and Nephew is we always have that on site and we collaborate with one another. So we've got those virtual tools, but the best thing is we've got the Smith and Nephew team. So we've had those problems with like physicians. We have like our general surgeons that, you know, they don't want to have that change. We've worked really close together and had that collaboration, teamwork, and that one-on-one, and worked through those obstacles, taught them hand in hand, went through that, developed that relationship and collaboration to agree on that plan to move forward, to help one another, to get over those obstacles for that change. That was the only way to do that. We met in offices. We sat in the ORs for months on end and with that 30, 60, 90 and went through that to get through those outcomes and to get through that change and have those conversions and have those successful relationships. That was a big part of that change.
It sounds like it was a true collaboration and no one just left you all hanging, thankfully.
Absolutely not. I mean, you start in the beginning, you work from the very beginning, from the get-go. It's teamwork. It's absolute teamwork. We all have to sit down and you devise a plan. You start together and you've got to trust one another. And we have to sit there and you work with the CMOs, you work with the C-suite, you work with the directors, you train the nurses, you train the doctors. You set up meet and greets, you set up show and tells, and then we've had pushback. We had pushback with general surgeons. We had pushback with cardiovascular surgeons. They have, they've seen one thing and they don't want to have that change. So you've got to evaluate. You've got to have those conversations. Some of those are very tough conversations, and that we've worked together. And like I said in the beginning, change is hard, but medicine is always evolving. That's the thing that we are in, and it's always evolving. So we're always changing.
So outcomes overall, it sounds like you all are still using the product after that hard change. How long have you all currently been using it now?
We standardized in 2019. Okay. It was a rollout. There was a plan in place. We started, did one division at a time, had a large plan in place, and it was laid out month by month. I believe it was a 6-month rollout. I think it was about 6 months this started. I think I rolled out in the Southeast Division. It took 3 months to roll out across the states out here. Slow and steady. Teamwork
wins the race.
Yeah.
Slow and steady wins the race for sure.
Absolutely.
Well, thank you for sharing your experience. That's really nice to hear. I think it gives people a lot of hope if they're looking at an implementation like this.
Right. Well, it's 30, 60, 90. You've got that monitor of success. You keep going. It's a 30, 60, 90-day plan, and you come back and you evaluate and you work together.
That's great. Dr. James, I know that you have already spoken to us a bit about why you've chosen to use PICO, ease of use. It has helped just leave something on. You have that security with reducing surgical site complications. So as a surgeon who sees so many high-risk patients, when do you choose to use something like a disposable negative pressure over standard of care? And when you do choose standard of care, what does that look like for you?
So when I decide to use a negative pressure system, particularly in an acute care setting, I have to kind of look at the types of wounds that I'm going to be managing and whether they're going to be a postoperative wound versus a large degloving injury or a wound of that nature. And once I've kind of categorized that, then I have to go through the processes. Is it going to be having excessive amount of drainage or minimal drainages in that process? And then finally, what size and shape bandage will I need to manage the wound that is there? So if it's a closed incision and it covers a long length, I know with the PICO system, I have so many options of sizes to fit my wound care needs as long as the drainage is minimal. And then finally, you know, I also try to just kind of see what kinds of patients they are, because sometimes you have patients that are going to be in situations where they may not be able to get back to you. They could be non-compliant. They could be very challenging in those regards. Or you have family members that are not sophisticated enough to understand what the bandaging is doing. And so you got to have a kind of a simple but effective system in place that allows you to successfully guide patients, families, and the places that you're working in to the endpoint, which is appropriate healing without complications.
I think what you said is so great, and it just shows how far negative pressure has come. Simple and effective. Who would have ever thought we'd be hearing somebody talk about negative pressure being simplified, but it really is with that. So I think that's so nice to hear how you can do that for your patients. Perfect. We are going to switch back over to Tammy here, and I want to know what the greatest benefit was to switch to the Smith & Nephew portfolio. You've definitely talked about that partnership. So of all the great things that you've already mentioned, what was the best benefit to you and your facility with that partnership change?
Well, there were a couple of them. The SKU reduction, I think Dr. James just mentioned it as well. You know, there was a SKU reduction, and it also gave them a vast, it gave the surgeons other options on different sizes. But the service from Smith & Nephew was also there. You've got that 30, 60, 90, and that collaboration that we have with Smith & Nephew now is very impressive. And that goes on to the home health and working with that and with the case managers and that ongoing and the ongoing education, the quarterly business reviews, and just the, you know, that collaboration and that camaraderie. So that we now have with them to work with our physicians and our new nurses. And that has been very beneficial to us. Just having that ongoing teamwork and that ongoing for our new physicians and our new nurses, and that has been very beneficial to us. To that, like I said, the SKU reduction, the new benefits for the new items, and that it's a different benefit of different sizes, different SKUs in that sense, and that collaboration of teamwork.
I think you said something key there, new nurses. We all know that there's constantly new staff coming in, whether it's physicians or nurses. So that's great that you have that continued partnership to capture those new people coming in.
Yeah, quarterly education, and you have to have that. Unfortunately, you have to have that, and it's wonderful to have.
Perfect. So we have several different folks joining us this afternoon from the clinical side, end users, and folks from the administrative side. So Dr. James, for those who have joined us who are curious and maybe even question a little bit, when facilities are looking to decrease the cost, right? We hear that a lot. We're wanting to decrease the cost. How do you justify using a disposable negative pressure on your closed incisions when there are other options available?
Well, not knowing all of the answers to the cost factors, I could speak from the experiences of the patients that have these systems in place, because depending on the payer, you're going to lower costs just by the fact that you're not requiring nursing care with the use of these bandages. Once the bandage is in place, it minimizes the need for ongoing nurse evaluation. So if you're dealing with outside agencies, you can reduce your costs, some of that there. If you do have a home health agency, the agency's costs, which should be passed down to the consumer costs, are reduced because of the time span that is taken to change a bandage versus with a certain vac systems, it's a little more time consuming. And then finally, the biggest one, in addition to the cost, it's also the cost of reducing pain and suffering. because when you change these bandages, depending on the system that you use, it can become quite uncomfortable. And my experiences with these particular bandage, patient after patient after patient, I usually ask them, how is the bandage working? How is the changes going? And they always conclude that they are having a wonderful or minimally discussed experience of it in a negative way, that the bandage system has affected them. So they're able to kind of go out and do normal things. And so the cost savings of being able to get around without large canisters and materials are very substantial, because you don't have all this extra equipment that you have to account for. It comes in a box. It comes with 2 bandages. It comes with the supporting tapes. It's a very compact, a very compact system. And I'll finalize that I've had patients that have had systems that, even if their payers didn't pay for the bandage, the cost of the bandage is so reasonable that patients will pay out of pocket for these, even though they might have a different system that will pay for it. They'll pay for this one because it's affordable. So a big key there, that these bandages are very affordable to the average person compared to these other elaborate systems that can run substantially more money out of pocket.
That's one of the things that I love hearing about. I think it can get lost sometimes. We talk a lot about decreasing the cost monetary wise, but you've definitely just touched on the human cost, which can sometimes get lost. And the human cost can be huge to these patients. So thank you for addressing that. Dr. Littlejohn, we didn't forget about you. Early on, you did start to discuss about your discharge process. So first, I'd love to hear a little bit about some of the concerns you had with your previous vendor with the discharge process and increased length of stay. And then we're going to flip it and hear about how your process has been since switching to Smith & Nephew. So first, again, just going in a little bit more detail about how important the discharge process is to you in your practice, and a little bit more detail about some of the challenges you might have faced prior to Smith & Nephew.
Sure. Well, there's a lot to unpack here. I can tell you that our patients in general do better at a certain point when they're home. The longer you stay in the hospital, the more likely you are to pick up hospital-acquired infections, pressure sores, etc. And so what we've learned over the past 50 years of medicine is that there's a certain population, which is most of the patients, that do better if they're discharged, they're more ambulatory, you even heal better in your own home. With that being said, our prior vendor was less than helpful, I would say, really helping us secure negative pressure wound therapy for home, or if we place something in the hospital on an extremity or a burn graft, for example, it would just take an inordinately long amount of time. So those are some hurdles that we had in the past, and those have actually gotten quite better with our upgrade, as it were.
Okay. So with that upgrade or that change, how did that partnership, specifically with Smith & Nephew, change some of those things that you were seeing?
Sure. Well, I've been here at Geisinger for about 3 years, and the change happened within my first year. And the tech support, and really just the support from Smith & Nephew began instantly, even prior to the to the switch. So that has decreased our length of stay in many of our burns, many of our wounds, and the fact that there is a hotline that the patients are able to call. I mean, they call us as well, so we get those pages. But I think it's really benefited our patient population, and it's really shifted some of our care from the inpatient to the outpatient side. Again, where patients are more independent and more comfortable at home.
I know I would definitely want to be at home. So we can all, I think, safely say we'd rather be at home. No, thank you for sharing that. I'm so glad that's helped you all with your practice and what you've been able to do for your patients. Tammy, I know we've talked about our 30, 60-day follow-up plans and ongoing maintenance and different things that the partnership has done for you. But I'm curious about the impact that partnership has made on your institution and your nursing staff and those who have to use these products.
It's been a big impact with the as we have kind of hit it a lot tonight. The 30, 60, 90, we have that constant education. We have the quarterly review. That collaboration to have that education. The reps are on call constantly for us. If there is ever an issue, we have such good teamwork with the reps now. They're on call for our team now 24/7. If we do have an issue, we can call them at any time. We've collaborated with education, so we've got new nurses in, and we do have an issue, we are able to call them. We have issues in our offices. We're able to collaborate and call anytime to set up some meetings so we can troubleshoot. We haven't been able to do that in the past. So we've been able to troubleshoot with those ideas, work through that. We always have that clinical support. If we get a new physician, we can help onboard them with our Smith and Nephew products. So it's a great tool to have. And like I said, I can't say enough about the collaboration. We've got a great team here with Smith and Nephew.
Thank you. So Dr. Littlejohn, I know earlier you mentioned the soft port and just being able to apply that maybe a little quicker, easier, more patient comfort. Are there any other clinical changes that you have seen in your practice since initiating or adopting the Smith and Nephew portfolio?
Sure. So anecdotally, because I don't really have data to support this, but I feel like our rates of pressure injury due to these ports are lower. I think they're pretty easy to apply for the extremities, for pressure sores that we have to debride. I think that in general, it's more comfortable for the patients, especially if they have large bandages or wrapping around things. But I've been quite happy with the soft port compared to our previous, I guess, not so soft port.
It's definitely a different technology.
Yes, yes, it is.
Yeah, definitely a different technology. Okay, great. Thank you so much. Dr. James, just a little bit about some of the benefits to your clinical practice by using the single-use negative pressure wound therapy system, PICO.
Well, since I work in two spaces, being the outpatient space as a wound care provider in an outpatient clinic and as an inpatient provider as a surgeon, the benefits of the bandaging system are manyfold. For example, if I have a patient that has had an operation in the main OR and it's a relatively clean, unfortunately, I'm still one of the few surgeons in the area that still do open surgery a lot. My younger colleagues do a lot of robotic and laparoscopic surgeries. Sometimes they're not able to do that because of prior surgeries. So open surgery is needed. So they have an incision, and these bandages that are placed there, the biggest thing it does is that it's left undisturbed. So if you have a clean operation and you put a bandage system that manages fluid, it actually enhances some of the injuries around the wound by the negative pressure itself, by being on the outside providing pressure and decreasing lymphatic drainage and removing all the seromas and protecting the suture line by having some of that negative pressure not tug and pull on your suture line internally. The benefits are substantial on the outpatient side. If I've got a wound care patient, for example, that I decide to put a skin graft on, that system in its variety of sizes allows me to do the wound graft, and I use the PICO Y in that situation. I could put a donor site PICO on one and the actual graft site on the same side and have one pump. And I've got the donor site and the graft site well secured, managing fluid and not causing shearing forces. And it's all wrapped up in a nice little bandage and sent home. And they have a little pump that, again, it's not disturbed. When you do skin grafting, the thing that you don't want people doing is messing with that graft in the first 7 days. And what is there a better bandage that you can leave on for 7 days that'll manage the moisture, secure the graft. And when you peel these things off 7 days from now, the donor site and the graft site are doing exceptionally well. And so, plus, again, they're very comfortable. And again, finally, they're very easy to put on in the operating theater. I personally have a harder time putting on open backs because you got to cut the sponge and everything to fit. I'm not a very good cutter in that regards. I just kind of cut it enough to stuff it in there and turn it on. But I know my staff on the floors can definitely put these other bandages on. And you get a lot of less phone calls. The phone call you get is like, should I touch this bandage? And the answer is leave it alone until I see it. And so the benefits to the practice are manyfold. And so like I said, I've been a champion for this particular system.
Thank you. It sounds like this little thing can do so many great, it has so many great mechanisms of action that you touched on. And it's amazing having a nursing background myself. I know if we can have something simple, we have a lot of things going on in today. So that's great. I'm glad to hear all of that. Dr. Littlejohn, I did ask this of Tammy, but I'm also curious to hear from you since you all have recently implemented. What was the greatest benefit to your facility when adopting this new negative pressure wound therapy system?
Well, I would have to say that assuming that the efficacy of both our current system and our previous system are the same, I think the main difference would be our support, right? Our reps are amazing. They help us at all hours. And then a close second would be, I know you only asked for one, but a close second would really be the ease of use, the interchangeability of the ports. And so I think that's really helped everybody from, us surgeons to the practitioners, even, in the nursing side. I think they have a better understanding of these systems and they're better able to use it. But I would say, again, number one, I really tout the customer support.
Perfect. And we'll definitely take two. Thank you for giving two, because I think a lot of those joining us today just really aren't aware of any other options. So hearing that it is so user friendly and you can easily switch from the acute care device to the home care device, I think that's great. So thanks for sharing both of those. I want everybody to hear that part. So I know we are nearing the end and we're going to open it up to question and answer. I'm going to turn it back over to Erica here in just a minute, but I really want to get you all back on the screen here, and I'm going to open this up to all of you, and I'll go in order. Again, I'll let you all know when we want to hear from you, but what advice would you provide other peers in your position who are considering changing to negative pressure? Tammy said the change is hard. We don't like change. So when you all are facing this obstacle in your facilities, again, what advice would you give your peers? So Tammy, I am going to start with you.
Keep an open mind. Teamwork is dream work. Nobody likes change. You've got to work together because we aren't successful doing it by ourselves. We did our part. Let Smith and Nephew do theirs. You've got to trust one another. That's the biggest thing. That's what made the standardization for us so positive and successful in our organization. And I will say, I meant to say this earlier, this standardization for us was so successful with Smith and Nephew that we've actually templated this standardization in my division, and we have modeled this so for other standardizations. So when we do other big ones in my division and looked at other areas too, we template it the way we did it here. We start from the bottom, the top up, top down. So we get that support because it worked really well. But you got to trust one another and work together.
Absolutely. I love that. Teamwork really does make the dream work. Dr. James, what about you? If you had a surgeon coming to you and they wanted some advice on how to change what they're currently doing, what advice would you give to someone in your peer group?
So in my peer group, I have multiple types of surgeons. I have cardiothoracic surgeons, orthopedic surgeons, general surgeons, plastic surgeons, urologists. You have these different, and vascular surgeons. That's a big one as well. You have to cater your conversation to the needs that they're expressing. And when you go through this particular product type, and the biggest thing that threatens all of them are SSIs. And I would tell them that if you are looking to reduce the number of SSIs and you have incisions, you ought to consider this bandage. Because I always tell them the wound is never cleaner until in the operating room. If you get this bandage on in the operating room, and number one, it's managing the wound with this mechanism of action that I would outline. And then on top of it, it's left undisturbed, your incidences of complications should go down. So I would always approach them that way. If you want to have less complications, you might want to use this kind of system.
Perfect. Thank you. And Dr. Littlejohn, again, you're talking to a group of your peers. What advice would you give them if they are staring at this undertaking of adopting a new negative pressure?
So I'd tell them to look at my outcomes. No, I'm just kidding. But I think, as surgeons, we all really hold ourselves to a high standard. If things go wrong, we look at ourselves first and then the equipment later. With that being said, I think we also all grew up in multiple stages of training using different machines, different techniques. Every surgeon I've ever trained with said, this is the way, this is my way. However, I would tell them, I would echo the fact that they should keep an open mind. I think they should try it out and maybe take a step back and think about how complex this is. So that there's a financial aspect of it, which unfortunately is a reality now. So we have to think about that. But also, the overall outcomes, how patients do, how fast they're able to be discharged. I mean, I think, we could talk for hours about the discharge process, but it's definitely going a lot smoother since our transition.
Thank you so much. It was so great to hear from all of you, and I really enjoyed your feedback. And I am going to turn it back over to Erica for a little bit. So, Erica.
Thanks so much, Allison. And thank you so much, Dr. James, Dr. Littlejohn, and Tammy. This has been a really great discussion, and it's interesting and really reassuring to hear all the great outcomes that you're all seeing with the PICO system. So thanks again for sharing all the details and best practices. So at this point, we're going to dive into our Q&A session. So for those folks on the line or joining our webinar today, please be sure to submit your questions that you have by typing them into the Q&A box that you see on your dashboard. And we already have a number coming through, so we apologize if we can't get to everyone's, but we'll try to get through as many as we have time for. Okay, so Tammy, I think we're going to start with you for this question. So we have a question about how the conversion seems like a big undertaking, which you've alluded to in your wonderful presentation. Was there anyone else from your facility that you brought in to help you outside of surgeons or clinicians?
Absolutely. Everybody, the entire facility. We worked with, we brought in everybody. We aligned from the top down. We brought in the C-suite. We brought in the CMO. We had conversations with the C-suite to let them know what was going on. We addressed and had conversations with the CMO. So we feel like sometimes we have that peer-to-peer with our physicians. We wanted the CMOs aware so they can have they had that physician feedback if there was issues, and those surgeons needed to have those conversations. We also brought in our educators so they can have physician clinician discussions. We also brought in our wound care nurses. We also brought in our EVS so they would know how to deal with the wound vacs. We also brought in any other leadership. It's teamwork, as I said more than once, I think tonight. It's teamwork. You have to bring it all in. It's not one person. We've got to collaborate together for success. So it was the OR directors, it was the nursing staff, it was the C-suites, it was EVS, it was everybody.
Thank you so much. So no silos in that conversion.
You can't. To be successful, you can't. You've got to bring everybody. You can't leave anybody out.
Absolutely. And Tammy, I want to stay with you for just one more question again about the conversion. So you talked a lot about a partnership with Smith & Nephew after the conversion. So this attendee is wondering, in what ways has Smith & Nephew been a partner post-conversion?
A 30, 60, 90 day. They didn't just come in and say, here you go, have fun, bye-bye. We converted, they stayed with us. They did a 30-day, 60 days, 90 days. They kept coming back. And then after that, we do business reviews. As a matter of fact, I had a quarterly business review today for the division. We do business reviews. We do monthly if needed. Education, I alluded to, turnover. Unfortunately, you have to deal with turnover in nursing staff. We'll set up monthly if we need to, education for our nurses in all of our facilities. So we have a 30, 60, 90, and we have that ongoing. It doesn't stop. So we have business reviews to make sure we have our pumps. The reps also come in and they make sure they do pump counts to make sure we don't lose our pumps. And they do their due diligence and they work really hard so we can keep up with our pumps. So we do that as well. And they help educate our case managers, because we do have turnover with case managers. So that is part, because our patients do go outside of the hospital. So we have to make sure our case managers are aware of how the transition works as well. So we have to work with them as well.
Great. Thank you, Tammy. It sounds like you have some really thorough support. So it's great to hear.
Thank you.
Yeah, so I'd like to move to Dr. Littlejohn for this next question. I'm wondering if you can say a little bit about whether there's a way for customers or those who are using the PICO system to get support after hours if they're having trouble with their discharge pump, for example. Can you talk about that a little bit?
Sure. Yeah. So besides calling our pager for everything, there is actually a 24/7 hotline that is provided through Smith & Nephew. And so that's been quite helpful. 90% of the time, that's an approximation, but there's some technical issue that they can be talked through over the phone. And like Dr. James alluded to, the worst thing you could do for like a skin graft or some of these wounds that we deal with is to disturb the pump. So you need to make sure it's working on the outside. So this hotline can be quite helpful and it's readily available to patients.
That's really great to hear. That constant support, I'm sure, issues happen at any time of the day. So that support's really necessary. And night. I should say that, yes. Wonderful. Well, thank you. And so Dr. James, I want to turn the next question to you. So in your presentation, you talked about the mechanism of action of PICO. And so I'm wondering, in your opinion, what do you think it is about the product that gives your patients such great outcomes?
So when you have a complicated wound, like in a wound center, you are spending an inordinate amount of time building their trust and accomplishing the goal of getting the wound to heal. And so you're debriding these wounds and you're putting products on and you're affixing these PICO bandages to them. What has highlighted the change so dramatically is the comfort that these bandages are applied with versus standard of care, where you're constantly changing bandages either every day or every other day or every third day, ripping a band. I don't use, well, changing a bandage. I don't want to use ripping. Changing a bandage versus leaving a bandage in place. That's what I like to call an active bandage, because the minute you put it on and turn it on, it's not a passive bandage anymore. It's something that's actively working from the moment you turn the switch on. And that active bandaging with the products that are used, and some of them are Smith & Nephew products as well, and the other different tissue substitutes that we use in these centers are monumental in seeing results. And in wound centers, for example, they get to see pictures week by week of the progress of their wounds. And so when they see progress, it's like biofeedback. When they see that biofeedback being so positive, and they're not uncomfortable, and they're able to manage and do things during their day because of how the bandage is constructed, you've got a triple win factor of things that work in the patient's favor, which then feeds back to the quality and the customer service surveys. They get very high marks for these things for that. And so when you have a system like that, that works in both inpatient and outpatients the same way, and is actively working to get their wounds to the finish line, it's very, very encouraging from everybody involved, from the patients, the families, the nursing staff, the home health agencies that come in and see these patients. They're all encouraged when they see all these positive things happen at the same time.
Absolutely. And I love what you said about the progress photos. You know, it's funny, I've only ever really thought about those in the context of like fitness or weight loss. And, you know, those are, of course, really motivating for folks. And so something like a wound healing, I mean, there's no reason that it wouldn't be just as motivating to take care of yourself or to feel that satisfaction from seeing progress.
Sometimes these patients have had wounds for months over months, and then you start this process and they finally see the healing. They tear up, you know, they're going like, man, I don't know why I didn't come here sooner. I don't know why everybody doesn't know this. It's literally something that's, we're not trying to keep secrets, but I just don't think that we do a good enough job in the medical community to champion different systems. We wait for the disasters to happen, and then it becomes a situation where, oh, we've got them to the finish line, regardless of the disaster that has happened. And so I like to equate it, and Dr. Littlejohn can attest to this. You know, we do the sick care. You know, if you do the health care, you don't do the sick care. But now that we're doing the sick care, we've got to sit down now and kind of manage the sick care through the devices that we collaborate to get together, and with the team of doctors, nurses, and administrators to get everybody to the finish line. And my goal is always, I never want to see you again. If I do my job, I'll never see you again. If I don't do my job, I'm going to be married to you guys for like years. I don't want to be married to you. I got a wife. Okay.
Dr. James, thank you. Between never want to see you again and sit care, definitely some memorable sound bites there. So thank you. All right. Well, we have time for just a few more questions. I want to kick this back over to Tammy. Tammy, wondering if you can speak to what kind of clinical support Smith & Nephew offers after conversion. You did talk about the clinical team, and I know some other supports, but I'm wondering if you can share a little bit about how they differ from the sales reps that you work with.
Well, after that 30, 60, 90, they don't leave. They're there. They're always there. They're there daily. They're there for our needs. They work with our physicians. They work with our nursing staff. They do the rounding weekly on our pumps. They are there for the education, and they help us. They do that education. They work with our nursing educators. They work with our clinical resource managers. They work with me. They continue to work with us. And when we've had some fire drills, be honest, we've had some issues getting pumps in. I've called them on the 4th of July And we pull together calls from wherever everybody is, and we get stuff done. And they don't just put them in and they walk off. They're available, and it's very helpful, and it's very reassuring. So they don't just put their product in, throw it on a shelf, slap it on, and walk away. They're there when we need them, and it makes a big difference. They're there for that, and they're also there for that education. You don't just throw that in and then they disappear. Where we have reps that throw their product on a shelf and then you don't see them again until, you know, they've got a new product and go, hey, look at what we have. So it's reassuring to have that.
I'm sure that ongoing partnership
It
really
is.
speaks for itself. Yeah.
You have no idea. It's great to have that kind of collaboration and partnership and teamwork.
Thanks so much, Tammy.
Absolutely.
So let's direct this next question to Dr. Littlejohn. This person's wondering if you can go into a little more depth about the soft port specifically. This attendee is used to the regular tubing and they're having a hard time understanding how the soft port might help in clinical practice.
Sure, that's a good question. So I also grew up with the regular port, as you say, nice and round and looks like a straw, so it all makes sense in our mind. However, the soft port is kind of flat looking, but really what it comes down to is the movement of the effluent or the fluids, right? So as long as the fluid keeps moving, everything is good. I think I could say with great certainty that patients have not complained about the soft port really at all. Whereas in the olden days, if you had the tubing going under the leg, they would potentially get a pressure sore, or even when you wrap something, you know, it sort of presses against you. So with the soft port, you have to be cognizant of how tightly you would wrap something over it. But in general, I think the fluid management is exceptional, with more comfort.
Right, comfort is key. Thank you so much. Okay, so I think we have time for one final question, and I'm going to kick this over to Dr. James. I know you alluded to a little bit in your presentation about what happens with the wound care after the OR. So this attendant is saying, or sorry, this attendee's question, they're saying they're a little hesitant to put something like this, PICO, on their patients for the simple reason that they don't want after-hour calls to increase. Do you mind telling me a little bit more about how this affects you after the patient goes home?
I would say that when you have a system like this, as long as the bandaging system is well explained, like Dr. Littlejohn's presentation, it has a flat, softer port as well. It also has this amazing technology that tells you whether or not it's leaking or whether or not it's saturated. You can look at a bandage and tell that it's saturated, and it will tell you. And since the bandaging system is so easy to replace or change, I think it would lower your phone calls, because you can constantly, if you have the type of nervous patient that has to constantly know what's going on in that bandage, they can just look at their pump, and their pump will literally tell them that everything is okay. It literally says on the pump thing, okay. And so they relax. Then if it starts flashing an orange signal, it's either going to flash orange and the bandage needs to be changed, or the bandage is or it actually shuts off. So the only phone calls you're going to get is if they're leaking or if it's saturated, and that can be easily managed. So I don't think it would increase the phone calls, and I think the bandage, the way it's designed, will lower phone calls, because it's just on, it just sits there and it flashes, and if you want to check it, they can just check it and they know it's okay. But that's a conversation between the practitioner and the patient to reduce phone calls. I always have a practice of giving them a lot of information, and then I said, look, I've given you all this information, but you can always call. I've learned over 30 years of practicing, when you tell people a lot of stuff and then you tell them to call them anytime, they flip around and say, I don't want to bother you. So they're kind of more like I preach this to my students and my residents as well. Give them a lot and tell them you can call them anytime. I bet you get a lot less phone calls. And then it's just, putting a bandage on them and say, see you next week, and you don't tell them anything, you get a lot of phone calls.
A little reverse psychology. That's really interesting.
I call it a Jedi mind trick.
Yeah, I think that's the technical term. Wonderful. Well, thank you so much, Dr. James, Tammy, Dr. Littlejohn, and Allison. This has been such a wonderful and dynamic discussion. I think anyone who's listening is going to walk away with a lot of actionable steps that they can take and a lot to consider. So thank you all again for being here.